Hello, everyone, and we're back. So, next up, we have Kate Knightley-Jones, who is a specialist midwife in perinatal mental health, and she's also an advanced clinical practitioner. And she's going to speak to us about recognizing and assessing perinatal mental health. Thank you, Kate.
Hi everyone. So I'm going to talk to you about recognizing and assessing perinatal mental health. So before we start, it's a bit of a sensitive topic. It can trigger previous or current issues that are going on in your own life. So just make sure that you reach out for support, and make sure that you talk to friends, family, colleagues, or anyone else that supports you. So before we start, a little bit about me. I'm a midwife, first and foremost. I'm an advanced clinical practice midwife. I'm the lead midwife for perinatal mental health where I work. I'm the lead midwife for Community of Practice for Advanced Clinical Practice Midwives, which is a bit of a mouthful. I'm a PhD student, but I'm a mum. So these are my two babies in this picture. One of them I gave birth to, one of them I didn't. I'll let you figure that one out. But essentially being a mum, I became a mum in 2023, has changed my life and changed the way I practice, definitely. So first and foremost, I want you to look at these women and just have a think about what you see. When you look at these pictures, what do you see? Because I see women that could be in antenatal clinic, that could be at booking, that could be coming into triage, and they look happy, right? They're all happy with their babies, having a lovely time, smiling. So these pictures were all taken in the week before these mothers ended their own lives. The family shared these pictures with professionals to give a message for midwives, for doctors, for GPs, for health visitors, to try and look behind the smile. Try and be professionally inquisitive. Try and ask a bit more, because you would never think that all these children are now motherless. So, epidemiology of perinatal mental health distress. It's a complex multifactorial illness that requires a range of methodologies to evaluate its complex medical, sociological, and cultural nature. Childbirth is long known to increase the risk of maternal psychiatric disorders, and women are at a particular risk of a new onset of severe mental distress in the early postpartum, and its clinical picture characterized by rapid deterioration. So this is something I'm really passionate about, is missing voices and disadvantage. So I work in a disadvantaged area. And health inequality is rife within the NHS, definitely. And it's something we need to be addressing to get better outcomes. So from the missing voices in the embrace, 1 in 9 women who had died had severe and multiple disadvantaged. And in 2020, women were 3 times more likely to die by suicide during or up to 6 weeks after the end of pregnancy compared to 2017 to 2019. So that's incredible figures, and something that we know about and is still not getting better. So it's something we definitely need to be addressing. Key messages that came out of this embrace and things that I think we could look at, and we'll go over, is that GPs should inform maternity services of past psychiatric history, and maternity services should ensure that GPs are made aware of a woman's pregnancy and inquire to the GP about past psychiatric history. So that is definitely a massive hole in the net. So when you get your booking form through, there should be a GP encounter with it, or you should be checking GP records. I can't tell you the amount of women I have found to have past psychiatric issues, serious self-harm attempts. So there was one girl who booked who had depression on her form. GP said, yeah, she had 1 episode of depression. And just by thinking that something wasn't quite right when I met her and I went through her A&E attendances, she was in intensive care 6 months before, after taking all of her grandmother's blood pressure medication as a suicide attempt, a serious suicide attempt. So making sure that we look at the dots, join up the dots, and make sure everyone's aware. If you think a woman's struggling or her mental health is deteriorating, have you called her GP? Has she seen her GP recently? Having professional curiosity is key in mental health. If the woman is already known to mental health services, they should be made aware that she's pregnant, and they have the same duty of care to the woman to inform maternity services. So again, this is stopping women slipping through the net. There have been women who have been under secondary care teams, such as CMHT, who would have a personality disorder and are actively self-harming, and the mental health team know they're pregnant but haven't told us, or we know they're pregnant and we haven't told their mental health team, and that's a massive risk for women. New expressions of acts of self-harm are a red flag. We're going to go through that a bit more in depth. And regard women with any past psychiatric disorder at an elevated risk, requiring individual risk assessment. And I think that's key here, is it's individual risk assessment. Sometimes we're very quick to label things as a mental health disorder, and not everything is a mental health disorder. Life is hard for people at the minute. I've had people ask, or I've been asked to assess people who, oh, well, she's really tearful because her mum's died of cancer. Yep, that doesn't make it a psychiatric disorder. We should wrap around support, but it's key not to label things as a mental health disorder if they're not a mental health disorder. And looking at loss of a child, either by miscarriage, stillbirth, neonatal death, or child being taken into care, increases vulnerability. And I think the key message from that is that we have massive services for women who have suffered miscarriage, stillbirth, loss of a child. But remember, the women whose children are taken into care are just as vulnerable. Just because that child hasn't died doesn't mean they don't deserve the same respect, whether, professionals deem it to be their unfit mothers, they have problems with drugs and alcohol. Nobody wakes up and thinks, I'm not bothered about my baby. There's a series of events that have led them to this point in their life, and to be treated with compassion is what's needed to heal and to move forward and to hopefully stop that cycle happening again. And we're working at the minute to make sure that women also whose children go into care receive memory boxes, just like women who lose children. It's exactly the same. And to make sure they have psychiatric support, just like women who lose children through death. Decisions on continuing, stopping, or changing medication in pregnancy should be made only after careful review of the benefits and risks of doing so to both mother and infant, and we'll come on to medication a little bit later. And records for all women who die, we won't go through that, it's not really relevant. And asking women about domestic abuse in a kind, sensitive manner at the first antenatal booking appointment or the earliest opportunity she's alone, and ensure that there's opportunity to have a private one-to-one discussion. I think we should be asking routinely, everyone. It can take over 100 times of asking for someone to admit domestic abuse, and you need to build a relationship with that woman before they let you into their kind of world and what's going on for them. So, risk assessment, mental health, exam and history. So the best place to do this is booking for sure, but keep asking. So I consider this, the purpose of taking perinatal history is a key skill. It's not just asking the questions on E3 or your booking or Badgernet, whatever you use that you'll trust. It's about having professional curiosity and getting to the bottom of what's going on, getting a clear picture of what's going on in that woman's life, what her support network looks like, everything around her. It's about asking the right questions at the right time, and it's more than just a tick box exercise. So perinatal risk assessment, some things that they don't put on the booking and things I want to know about, or I think are key to know, is, was this pregnancy planned or was it unplanned? How does she feel about that? How is that going to affect her life? If she's a mother with 6 children scraping by on benefits, how is a 7th pregnancy going to affect her? If she is a high-flying lawyer in the city and this is an IVF pregnancy and now her world's about to change, how is that going to affect her? Are there any concerns or difficulties in bonding? And this is one of my main bugbears, is about open questions. So when I just had my baby, a lovely community midwife came round and said, "Are you loving being a mum? Are you loving it?" That gave me absolutely no space to say, do you know what? This is actually one of the most difficult things I've ever done. This has changed my entire life. I feel like I've got no control and I don't know what to do. That's what I wanted to say. But because she said, "Are you loving it?" I felt like to go, yeah, I am, yeah. So asking open questions. How do you feel about becoming a mum? How do you feel about being pregnant? Do you feel like you're bonding with your pregnancy? Do you feel like you've started to forward plan? When you look to the future, tell me what you see. These are some questions if I've got concerns about difficulties in bonding. And knowing what to do with the answers is very difficult as a midwife to have these difficult conversations, and to hold the woman's anxiety can be really difficult. So we'll go on to what to do with some of these answers. So obviously we ask about current alcohol or substance misuse in the mother or the partner. Lack of social support, housing, financial problems. Again, these are all impactors and stressors on perinatal mental health, all lead to women feeling like failures or not good enough mothers, or the reason that they don't want to be here anymore, or severe anxiety. What's going on for them in that world? And, if mum starts turning up to clinic and you notice that she's not looking the same, if she's got stains on her clothes, if that's not quite right for her, if that's what she can present to the outside world, what's going on in the inside world? What's the inside of that house look like? For me, I would want to be going to that home and having a look inside, or asking my community midwives to go and do a home visit, especially if there's other children involved. Are there any recent significant life events that were going to impact? So we spoke about the woman whose mother had passed away. That's an awful thing to go through, especially when you're pregnant, when you need your mum the most. How's that going to impact on her pregnancy? What wraparound support can we put in for her? Has she had any serious obstetric complications, any stillbirth, emergency cesarean? I mean, the report came out this week on birth trauma, which was shocking. Asking questions at booking. How do you feel about your last birth? Some people will go, oh yeah, it's fine. And others will say, do you know what? I found it really difficult, or I found the midwife didn't do this, or the doctor didn't do that, or it opens up a conversation. Have they got any physical health problems that are going to impact on their mood, their mental health, their welcoming a new child? And have they got a chaotic lifestyle? So we've all got that friend that lives in absolute chaos. And there's a lovely quote, which I love. It's, what's chaos for the spider is normal for the fly. Sorry, no, what's chaos for the fly is normal for the spider. It's one of the way around. I can't remember. It's from the Evans family, but I love it. And it's, what is their lifestyle like? Are they putting children to bed at 11 p.m.? Have they got people coming and going? Are they on the edge with finances and money? What does their lifestyle look like day to day? So these are all things to consider in the initial booking assessment, or when you feel like you've bought a relationship with that woman. So main sections of your perinatal history, you've got your basic details, the pregnancy, postnatal. So if she's had children before, I always want to know, how was that postnatal period for you? Did you struggle? Was there anything that was difficult for you? How do you feel like you're going to cope with 2, 3, 4 children? Have you got any present mental illness or history? So again, this is something that's really important for me. So when people say, I've got OCD, great. When was that diagnosed? Who diagnosed it? Because 9 out of 10 times we're finding that women will self-label, self-diagnose. And that's fine. We can get a diagnosis if she feels she's presenting with those symptoms. But actually, at booking, I want to know who diagnosed you, when was that diagnosed, and have you had any treatment or management for that condition? Because that will change my management plan or your management plan for that woman completely differently to somebody who feels like they're self-labeling for, oh, I've got OCD. Okay, tell me how your OCD presents in your everyday life. Well, I just like things clean and tidy. Again, that's not OCD. Whereas someone is, say, I've got OCD, I have to check the door handle 10 times before I go out, or I have intrusive thoughts. These are things that we want to know. How does that present? How does it affect their everyday life? And how is it going to impact upon the pregnancy? How's that going to impact upon the postnatal? And if we can put things in early, we start to reduce these risks down and down and down again, putting that safety net underneath the women, cocooning them in a support network. So should they fall, should they wobble, we're there to catch them. Their family history. So this is really important. If a maternal relative, so mum, grandmother, sister, on mum's side has got bipolar, schizophrenia, psychosis, that increases mum's risk. So it'd be something to note and something I would ask for if mum presented unwell in the early postpartum or in pregnancy. I would ask, what's her family history? So her personal history, her social history, her past medical, drug and alcohol. So when we think of perinatal risk assessment, mental health carries risk with it. It always does. And when I first started in mental health, it's something I really struggled with. And now it becomes part of my bread and butter. So it can make you uncomfortable to carry risk. But when I look for a risk assessment, these are things I'm looking up. Is there risk of self-harm? Now, self-harm in itself is an expression of a feeling. Okay, it's not always a crisis. Like, some people may binge eat, some people may have loads of cigarettes, some people may go to the gym. For some people, self-harming is a release, it's a de-stressor. Now, there should be other ways to put healthy coping mechanisms in, but it doesn't always make it like a big emergency. So what is their risk of self-harm or suicide? So when someone tells me they're suicidal, that's a big fact, a big statement. And it's good to note that sometimes suicide can be a feeling. It doesn't have to be an act. So one of my main questions I ask is, do you want to die, or do you just want what's happening now to stop? So you can just catch your breath and get better. And 9 times out of 10, they'll say, that's what I want. I just want what I'm feeling to stop. I don't want to die. I just need this to get better. So in the times where I have had women with clear suicidal intent, they have made plans. So a lady came into clinic and said very clearly that she's had enough. She'd written some letters, and she had very clear in her mind that she was going to go and get her toddler from nursery and go to the Dartford crossing and jump. So that is completely different. That is high risk. That is an emergency. We should treat that like we treat a PPH, like we treat shoulder dystocia. That has clear intent. Okay. There is risk. Is there a risk of self-neglect? Are you looking after yourself? If you're a diabetic, are you managing with your medications? If you're very depressed, are you managing to do your blood sugars? Are you managing to eat the food? And looking at these things, if a woman comes into clinic and you're seeing that she's not managing her blood sugars and she doesn't really seem interested in a treatment, why is that? Why is she not engaging? Trying to scratch the surface and look a little bit deeper. Is there risk of harm to others? Has she got any thoughts that she wants to harm anyone around her? Has she got any delusional behavioural thinking that people are trying to harm her? Or that the baby's involved in the delusional or obsession thinking? This is more with psychosis, schizophrenia. Is there a risk of harm from others? So is there domestic abuse going on at home? Are you being exploited? Is there sexual abuse going on? Is there a significant deterioration in mental state before, during, or after their pregnancy? So where has this gone wrong? At what point has things started to unravel? If you can pinpoint that, you can pinpoint the situation around what was going on for them at that time and make a better care plan for them. So these are kind of some of the stuff that you would look through in your pregnancy, in your booking anyway. But how does a woman feel about the pregnancy we've talked about? And what's really important as well is looking at was this the right time for her to conceive? Is she looking forward to the baby's arrival, preparing for the baby's arrival? Little questions like that seem innocuous, that don't, without saying, are you bonded, which can be quite a loaded question. Have you started to prepare the nursery? If she's 36 weeks and the answer's no, alarm bells want to start going off. Are they engaging in the pregnancy at booking? Are they asking you relevant and insightful questions? Most obviously, if you've done this 4 or 5 times, you might not have them. But as a first-time mother, or even second time, are they asking, oh, do I need a scan? Oh, should I be taking this? Can I eat that? These things would give you an indication that they're bonded with their pregnancy and invested in the pregnancy. So previous experience, something we're seeing more and more of now is women that have suffered sexual abuse in the past, or sexual assault or rape. So sometimes women will disclose, sometimes they won't. But what we know is that it can take sexual assault survivors a long time to disclose. So making sure that you ask them, is there anything about the birth that worries you? Or is there anything in your history that may worry you about having intimate exams? Things like that, where you're not directly asking them. We don't need to know the ins and outs of it. As midwives, that's not our job to unlock that box. We just want to know what we can put in place to make them feel really supported. And asking the woman directly, what anticipated problems have you got? Are you worried about anything? Have you got any other wider, issues such as housing? Usually these are offered up to us, but it's good to be professionally curious. And this is what I think is one of the most important, is who is your support network? Is the father of the baby involved? So I can't tell you how many times when we'll go, father of the baby declined to answer. Why? Why are you declining to answer? Is it because you don't want him to know you're pregnant? Is it because you're worried because you're claiming housing benefits and you should be leaving, all these types of things? Is it that he is in prison? Is it that he shouldn't have contact with children? Why? We need to look at why. Always keep asking yourself why. notoriously a nosy person, and professional curiosity is what can save lives, definitely. So if the dad isn't around, if this is a mum on her own, no problem. Who else have you got to support you? Where are your parents? Where are your family? Where are your friends? Because your support network is who we're going to call on. So moving forward, if you get that referral and you think there's something wrong, referring on, as midwives, we're trained to look at the normal, not the abnormal. So if you know something's wrong and you want to escalate these concerns, these are the type of things as an advanced practice midwife, as a mental health midwife, that I would want to know. What are the presenting features of her problem? So is she lying in bed all day? Is she really anxious and can't sleep? Is she having intrusive thoughts? Is she hearing voices? Is she seeing things? How is this impacting her life? What presenting features are you coming to me with? When did they start? Have this been going on for a day, a week, a month, a year? Is this a long-term condition? Has this been something she's been experiencing since she was 14 and never had help for it? Are there any specific triggers? So like we talked about sexual abuse, is it the intimate examinations, or is she worried about the birth? Is that she's got a needle phobia? What is triggering her to feel like this? How are the current issues impacting on her life, her family, her relationship, her work, her friends, and her functioning? So we see women in antenatal clinic maybe an hour, 10 minutes here, 10 minutes there. But these problems run deep through their lives, like roots of a tree. It will go down and it will spread. So is she managing her other children? Is she managing to get them to school? And a lot of the time, when things fall apart and serious outcomes happen and we all come together for a quick case review, which is what part of my role, is we'll see that actually her other children started to be late to school and the school were a bit worried but didn't really say anything. Or the health visitor will say, well, yeah, she did DNA, a couple of assessments. And then the GP might say, well, we haven't seen her for years. Or she did come and say she was a bit anxious, but she never picked up the prescription. And when we start putting these pieces of the puzzle together, that's when we're getting a view of how things have gone. It might be that she can't go to work anymore, so she's relying on food banks now because her mental health's impacted, or she's now not making rent, so she's now homeless. And it's about catching these things at the beginning so it stops the unraveling happening. And one of my favorite questions to ask is, what do you think would be helpful for you? Because what might be helpful, what I might find helpful in support, someone else might absolutely hate. So what is it that we can do to support you at this time to get better? Or what is it that we can do to support you at this time to help with the pregnancy in your wider life? That's a key question to be asking women. So some things, past treatment, when we talk about past treatment or current treatment, we've got two kind of treatment prongs for perinatal mental health. We've got medication, we've got our antidepressants, antipsychotics, antiepileptics, and anti-manic agents. Or we've got our talking therapies, our psychotherapy, psychoeducation approach, CBT, psychodynamic counselling, there's lots. So you can take a two-pronged approach. You can have medication and talking therapy. You could just try talking therapy. You could just try medication. And this is why it's important to ask the woman. She should be the key driver in the decision-making process. We are just there to support her. I'm going to skip that one for now. Talk about that. So personal history, when we look at a woman's personal history, every human has got building blocks, and our building blocks of our life make us to who we are. So when we're looking at early childhood, did she have any ACEs? So, did her parents split? Was she born to a mother who's addicted to drugs? These things are really important. They may not seem it at the time, but they absolutely are. And there's so much research, which we'll come on to, which supports that. Looking at her childhood trauma, was she abused? Did her parents separate? Was there any deaths in the family that affected her? How was school life for her? Was she bullied? Did she go on to achieve any academic qualifications or any other education? Has she got any employment? What are her relationships like in her life? Has she got friends? Is she in debt? Has she got savings? Obviously, some of these may not feel comfortable going into, but if she reveals that she's struggling financially, these are things that we need to be asking to see how we can help her. What's her networking? What's her community like? And other questions that we would ask routinely, really. So when I assess somebody in perinatal mental health, these are all things. This is called a mental state examination, and this is something that we're taught to do in mental health to get a clear picture of how the patient presents. And it's something that I think as midwives we could really bring in, or at least have a good understanding of. So appearance, what is her clothing and what's her self-care? So if she's coming into clinic, for instance, it was last winter, and a young girl came into clinic with her little boy who was 2, and he came in a t-shirt, joggers, and a pair of Crocs, and she came in a t-shirt. I said to her, "You're not cold. You must be freezing." And all that was, she burst into tears, and that was the start. She said, "I'm really depressed. I can't go to work. I can't afford to get the baby a coat. I've got no one to support me." And just that one question unraveled everything. So taking note of what are they wearing. If someone's presenting to triage and they're saying they're suicidal, when someone comes to A&E and they're suicidal, first thing the A&E nurse, triage nurse will note down is exactly what they're wearing. Because if that person goes AWOL, we've got something to tell the police that they were in a grey hoodie, black leggings, pink Crocs, hair in a bun, 5 foot something, slim build, pregnant, how many other weeks pregnant. Because I can guarantee you at the time when they go missing and panic sets in, the police have done studies that show that you won't be able to recall what they were in, what your memory will start to go fuzzy, and you start to try and piece things together. So also, if they present unwell, psychotic, you're at a home visit, or they've come in a bikini top with jogging bottoms, that's not quite normal, is it? So looking at their clothing and looking at their self-care. And with people who become unwell with depression, you may see that their self-care comes straight down, that they start presenting very unkempt, and that's not normal for them. Or with people, highly anxious women, I always worry when I go to home visits and it's day 1 post-section, the mum's got a full thing of makeup on, hair straightened, in immaculate clothes and up. Like, for me, again, that's a worry. So what's their behaviour like? Are they making eye contact with you? What's their rapport like? Are they agitated? How are they interacting with their bump, with their baby? What's their speech like? Is it really, really quick and you can't really follow it and you don't really know what's going on? Is it really slow and it seems a bit odd? Are they giving one-word answers? Is it really, really loud and they're shouting at you, or are they whispering and they seem to be whispering to themselves? These are all things that are really important. Is their speech normal? What's their thought form? So when we talk about thought form, it's like, did you ever play that game when you were a child, the word association game? So you might go apple, okay, what's related to apple, cheese, cheese is mouse, mouse is, and you go on. Are they being able to form their thoughts normally? Are they having flights of ideas? So, for instance, when I saw one lady, they offered her porridge for breakfast, and that was it. Porridge was curds and waves with Miss Muffet. Miss Muffet sat on a tuffet, and we were off on this thought. This flight of idea had gone. And it also presents as muddled thinking. So can they coherently have a conversation with you, or are they muddled in their presentation? And their thought content, is it depressive? Is it anxious? Is it psychotic? Is it delusional? Or are there overvalued ideas? So when I say overvalued ideas, what that means is everything's absolutely the best. So I had one lady present in clinic who lived in a high-rise flat, but she had bought a racehorse, and this was it. This £8,000 racehorse, she was going to win the Derby with it. It was, that was it. And this is these overvalued ideas that it was going to be the best thing. And actually, she was in a manic bipolar episode. But these overvalued ideas or delusions are what feed in. And perceptions, are they hearing things, seeing things? Are there any physical delusions? So sometimes people can feel things crawling on their skin. And what's their mood, their insight, and have they got any suicidal ideation? So I always say to my women, have to ask, have you got any intent to harm yourself or others? And usually women are quite open and honest with me about it. So looking at the wider picture, we now need to look at perinatal risk and child needs screening. So So thoughts of harming the baby or other children. Is the baby or child in contact with the perpetrator of abuse or any other risky adult? Has children's social services been involved before, during the current or previous pregnancy? Is that child subject to a child protection plan, or have they been? Are there other concerns or welfare of the child, including the care of the child or enjoyment of the child? And has anybody else got concerns? And that's where we talk about looking at the wider picture, speaking to GPs, speaking to health visitors. Has anybody else got any wider concerns that you're not seeing those pieces of puzzles? Now, I want to make it really clear that just because women have mental health disorders doesn't mean we need social services involved. It's about the risk, and any perceived risk, I would talk to your safeguarding lead, talk to your mental health lead, and I would also have a frank and open conversation with the woman. Never refer someone to social services behind their back. It just breaks the relationship. So things you need to be looking out for in practice. These are red flags. So if you get a referral through for pregnancy, anyone with bipolar, schizophrenia, psychosis, previous psychosis, self-harm, suicide attempts in the last year, or an inpatient admission in the last year to a psychiatric unit, these should be your red flags. These should be your warning signs. These need multidisciplinary team involvement. They need early referral to perinatal teams, and they need a full history taking on them. They also need you to pull their records back. Why were they an inpatient in the last 2 years? If they've had suicide or self-harm, how did they try to do it? What was the risk? You know, is it superficial cutting, or are they taking a whacking great overdose? This will help you in risk assessing. And then other red flags. So these are presentation red flags. So presenting in the first week postpartum, unwell. This is a high risk period for presenting psychosis because of the change in hormones. Thoughts of violent suicide. We know that perinatal increases the risk of violent suicide. Sudden deterioration of mental health presentation or new symptoms. Estrangement or feeling estranged from the infant. So that might be not preparing for the baby, not, you know, being engaged with the pregnancy, not wanting to hold the baby, feeling incompetent as a mother. So things like, this baby would be better off without me. I'm a terrible mum. I can't do this. Thoughts of absconding. I just want to run away and never come back. Previous histories of suicide attempts, thought to harm the child, psychotic thoughts relating to the child. So the child's trying to harm me. We've had one lady, the child was the devil trying to get to her, and high risk symptoms in previous presentations. So is she keep coming with small little bits of psychotic or delusional behavior or severe depression, and now the puzzle is building, the risk is building. So these are all red flags you need to be on the lookout for. So why is this important? So the first 1,000 days of life from conception to age 2 is a critical phase, which is the foundation of a child's development laid. This is the building blocks of who we are. If a child's body and brain develop well, the life chances are improved. Exposure to stress or adversity during this period can result in a child's developmental falling behind their peers. Left unaddressed, experiences such as abuse, conflict between parents can stay with children throughout their lives. They can cause harm to them and to others and may be passed on to the next generation. Individuals with 4 or more adverse childhood experiences are at a greater risk of poor health outcomes compared to those with none. They're also 30 times more likely to attempt suicide in their life. Intervening more actively in the first 1,000 days of a child's life can improve child health development chances and make a fairer society and more prosperous. So my master's degree and my research was on outcomes of children with personality disorder, of children born to mothers with severe personality disorder, and they were 60 times more likely to end up in the prison system, less likely to earn the same count as their counterpart, less likely to go on to higher education, and more likely to have poor or ill health such as heart disease, and more likely to engage in drugs and alcohol. So if we can intervene in the early days, we can stop this cycle, and this is why it's so critical to put that network around the mother. So suicide prevention, we've got some key steps here, which is identification and assessment. So having our care pathways from pre-pregnancy to postnatal period, assessment at every consultation about mental health and well-being, early intervention at all levels, correct diagnosis, considering our high-risk groups, which is our bipolar, schizophrenia, previous psychosis, and exploring their full history. Making sure they have the correct treatment, supportive care, talking therapies and medications, information and awareness, information leaflet to women, their family members, what to look out for, who to call in a crisis, where they can receive quick help, and care coordination, making sure that we're all joined up, that we're all an MDT together, including our obstetric colleagues, our health visiting colleagues, our GPs, our schools, making sure we're all one and that information is being shared. So safety mental health medications, we use the same that was been spoke about all morning. We have the bumps, the tetragenesis service, and we also have this lovely this one in the middle, this Pan London Perinatal Mental Health, that's got all the psychotropic medication in their relevant infant dose risks and the what you should be looking for in mum. But the bottom line is, do not stop medications in women without advice. The risk of relapse is high, up to 70%, particularly dangerous in bipolar disorder, and they need an individualized decision-making process. I can confidently say, as a prescriber, SSRIs pose a very, very little risk compared to the risk of relapse. Do not stop them. Get expert advice, call your mental health midwives, call your consultant obstetricians, call your on-call perinatal pharmacist. And when I say perinatal pharmacist, it's because if you go through to a normal pharmacist, they will probably just read the risks that you could find online. You want a perinatal pharmacist. And where to get help. So in a crisis, you've got your crisis teams, your psychiatric liaison teams, you've got A&E, you've got 999, you've got your perinatal team, you've got GPs, health visitors, perinatal mental health midwives, obstetricians. There's lots of support out there for women and for you to support women. And I'm just going to finish on this few little bits because I've been collecting these over a couple of years. So I've been doing this job for 7 years now. I've been collecting these. So these are some absolute corkers that professionals have said to women. So they said to me, have you ever tried reading Robinson Crusoe? This was in response to a woman telling her GP she was suicidal. What have you got to be sad about? You're having a lovely baby. That was from a midwife to a woman who was crying in clinic. Maybe you wouldn't be so depressed if you stopped having children. That was said from a midwife to a lady who's on her 6th pregnancy, struggling with money. Well, if you managed to get pregnant in the first place, and that was said to a victim of childhood sexual assault by a consultant obstetrician who was, as the woman was requesting an elective cesarean. All this crying is impacting the baby. That was said from a midwife to a woman in clinic. Have you tried having a bath in response to a woman telling her GP she's suicidal? Why bother coming here to see me if you don't want my opinion? I'm the doctor here. That was from a consultant obstetrician from a woman wanting more information on psychotropic medication. You don't look very depressed. Are you sure you're not just being a little bit dramatic? Could be your hormones. That was said from a midwife to a woman who was opening up about her depression at home. These are absolutely shocking, and these are not the behaviours that we should be exploring as health professionals, exhibiting as health professionals. Now, I'm also about fairness. So these are some of the most lovely things that I've heard. The doctors and midwife were the only ones who made me feel supported and cared for, like I really mattered. The consultant listened to me, looked at me, and made my life as a whole. Looked at my life as a whole and made decisions in partnership with me. And this is how it should be. It should be a partnership, not a dictatorship. The midwife saved my life. She turned off her computer screen and just listened like she had all the time in the world. I know she didn't. How amazing that someone could take the time to do that, and that woman really felt listened to and heard. The midwife made me feel normal again. All these things in my head made me feel like I was going crazy, but she reassured me and found me the help I needed. I had a traumatic delivery. The doctor who delivered my baby came back to see me. She told me what happened and what a great job I did. In that moment, I didn't feel like a failure anymore. The midwife told me that the midwife told me that she was going to support me through my antenatal depression, and I truly believed her. And then the last one, my midwife asked me at every appointment how I felt. It took 4 appointments before I could tell her the truth about my OCD. And these are the really heartwarming things that show the difference that looking after women with perinatal mental health can do, and that we can intervene and be the difference for the next generation just by having professional curiosity and spending a bit more time. That's it.
Thank you, Kate. I really, really enjoyed that. I thought that was really interesting and really informative. One of the things that I was thinking about is that with the current cost of living crisis, I think everybody's reporting that they're hearing way more mild to moderate anxiety and depression in the women that are coming through. And with the cutbacks to services, it's difficult to know what to do because perinatal psychiatry is quite strict on what they'll take. And so when we're asking the Hooli questions at booking, if people are saying, yes, I'm feeling quite depressed or I'm feeling very anxious, what's the best thing to do in that first initial meeting?
If it was me, I think the Hooli questions are great because they help pick us up on uh, what's going on, but it doesn't really delve deeper. So I'd want to know why, what's going on for you in your life. And by looking at the bigger picture, like you said, mild to moderate's on the rise. Are you anxious and stressed because your husband's just lost his job and you're struggling to feed your family? Because then we can look at supporting you with food banks, with donations for the baby. We can look at supporting you in group therapy. There's 100 of different ways we can support you, but it's making sure that you're targeting the right support for that person at that time and climbing the ladder of support rather than,
Mhm.
just referring to perinatal teams who may not be appropriate and actually may not fix the problem at all.
Yeah, yeah. Thank you. And then somebody has asked in the chat, is it acceptable to ask women about any potential ACEs and if present to talk about their potential impact on their mental health?
I absolutely think it's acceptable because you're building a picture of that woman's life and you're building a picture of what support she may need. I can't tell you how many times I've had a lady came into clinic and she'd shrommed and she was declining to have an amnisure. And actually, when we sat and talked about it, about why she didn't want to do it, it's because she'd been sexually assaulted as a child by a close family member and that was
Yeah,
impacting on the well-being of her and her baby. And when we said, okay, is there anything we could do to make you more comfortable with the examination? We found out that she'd like the door to be left open because that made her feel better and more controlled. She didn't want the door to be closed or locked. There were certain words that she couldn't use, and there were certain things. So, for instance, a lot of times I've heard practitioners say, "Well, why did if she didn't like it? Why didn't she tell me to stop?" When people are being raped or sexually abused, often they will cry
yeah,
for them to stop, and it hasn't stopped. So for this young girlie, we said if she raised her hand or waved her hand, everyone would stop what they were doing. And for her, that gave her back control. So yeah, it's building a picture of what's going to help them and making them feel supported. It's definitely important to find out how their lives progressed to this point.
yeah. Brilliant. Thank you so much, Kate. Um,
Having me.
that's all the questions that we have.